So we are starting.
Yes.
Just call Dr. Soumya, who is supposed to present the pancreatic blastoma.
To take the other one, take pleuropulmonary blastoma, whichever is available.
Okay, ma'am. Okay. Sure.
Yeah.
Sure.
Okay. Yeah.
So with all your permission, I'm starting the session. Good evening and a warm welcome to all the dignitaries present here. I'm Srivastava from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this event, hosted by the Cancer Kids Strength of Smiles Doctors Network Maharashtra. And the focus of today's session is Ekatrasetu Webinar Session 2 on rare tumors in pediatrics. So let's begin today's session, for which I would like to introduce the moderators of today's session, Dr. Sidharth Totadri sir and Dr. Saurav Srivastava sir, and the coordinator of today's session, Dr. Pankaj Divedi sir. So let me share the CV deck. So yeah, Dr. Siddharth sir has done DM in Pediatric Hematology Oncology at PGI MER Chandigarh. Next we have Dr. Saurav sir. Sir has done MCH in Pediatric Surgery. He's assistant professor at AIIMS Patna. Next we have Dr. Pankaj sir, Pediatric Oncologist at National Cancer Institute, Nagpur. So without any further delay, I would like to hand over this session to Dr. Saurav sir. Sir, please proceed with the talk.
Thank you. I would like to welcome our experts, Dr. Abdelhafeez sir, who is an MD Assistant Member, St. Jude Faculty, Director of Pediatric Surgical Oncology and Fellowship Program at St. Jude's, Memphius. I would also like to welcome Dr. Sandeep Jain sir, the Senior Consultant of Pediatric Hematology Oncology at Rajiv Gandhi Cancer Institute, Delhi. I would like to also welcome Dr. Sidharth sir, if he has joined yet. I cannot see him. Dr. Siddharth Laskar sir.
Hi, I'm here. Hi.
Good evening, sir. Professor Radiation Oncology at Tata Memorial Hospital, Mumbai. And Dr. Kunal Sharma sir, Associate Director and HOD of Center of Excellence in Histopathology, Global Reference Laboratory, Agilus Diagnostics. For the first presentation, we are proceeding with the pleuropulmonary blastoma. Can I share my screen, please?
Yes, sir, please.
This is being shared by you.
I have stopped sharing, sir. You can share now.
Okay, right. I'm unable to share right now.
Sir, you need to click on the share screen option, the green colored option. Yeah,
I did that.
Then you need to choose the presentation which you want to share.
I'm not getting that option.
What are you seeing, sir?
Screens, it is desktop 1, something like that. Document.
WhatsApp me your presentation.
Not able to see any option of sharing. Okay, can you share that?
Can you give it to me? I'll share it.
Sir, you can share with Dr. Monica, ma'am.
Achha, I've got it now. Okay. One second, I've got the option.
Should I ask Dr. Faiza to share, because I think she is going to start?
Yes, ma'am. Yes, ma'am. Please.
Dr. Faiza, if you're ready, you can start
I
sharing
am
your screen.
ready. I am ready.
Hi.
Shall I share?
Yes.
Shall I share my presentation? Okay.
Yes.
Okay, can you see my presentation?
Yes, ma'am.
Okay, and you can hear me well?
Yes, ma'am.
Yes.
Perfectly.
Yes.
Okay, greetings from Bahrain. I'm Dr. Faiza Haider. I'm a pediatric surgeon from the Kingdom of Bahrain. I would like to thank Dr. Monica for allowing me to share this presentation with you. So the topic is rare diseases, and we're sharing our rare disease as well. So this is the institute I come from. It's Salmania Medical Complex in the Kingdom of Bahrain. You see how we've evolved over the years. So the rare diseases, we don't have actually a single widely accepted definition. In Europe, it divides it as 1 in 2,000. In the US, 1 in 200,000. So the definition in the medical literature and by national health plans says it's ranging between 1 in 1,000 to 1 in 200,000. There are at least 6,000 rare diseases. 2/3 of them with these rare diseases are children. 80% of the rare diseases have genetic components. The World Day of Rare Disease is the last day of February, whichever it becomes, and the World Day of Childhood Cancer is the 15th of February. I'm sure everybody knows that. So I'm sharing a case who's now 10-year-old, but during the presentation was 6-month-old, referred from a private clinic with 2 weeks history of cough and shortness of breath. So the mother gives history of cough for 3 months, which increased in severity 2 weeks prior to presentation, and everything else was negative. They took him to private clinic where he was diagnosed at 6 months, mind you, as bronchial asthma was treated, but did not improve. So they went to a pediatric pulmonologist where he did a chest x-ray after finding that he was tachypnic and there was marked decrease air entry in the right side of the chest. We did not have the films from the private, but they gave us a report of increased hypertranslucency with large emphysematous poly in the right hemithorax with shifting mediastinum to the left. Immediately, they referred the patient from the private to our institution. Upon presentation, the vital signs showed a heart rate of 170, respiratory rate of 62, temperature was normal, as weight at that time was 7.4 kg. He was conscious, febrile, and satting 95% on room air. Again, on the right side of the chest, there was marked reduced air entry, no wheeze or crepitation. Rest of the physical examination was unremarkable, apart from a small strawberry capillary hemangioma over the right forehead. Laboratory investigations were almost within normal limits with the hemoglobin of 10.8 and a normal white blood cell count. This was the chest x-ray upon presentation in the emergency where what the private had referred to with a multiple bully and shift of a mediastinum. So we proceeded to a CT. Again, it was reported as an emphysematous lung with multiple bully. So he was admitted to the pediatric ICU with these findings. They requested a right-sided ICD, which was inserted upon this request. Throughout this patient was under chest and not under pediatric surgery. He remained stable. The CT chest was discussed as the condition wouldn't improve, and they again reported it as emphysematous lung with no pneumothorax. So we decided to take the patient for surgery on the 4th day of admission, and we took him right thoracotomy and right lower lobectomy. Upon surgery findings, we had found a hemorrhagic multiloculated cystic lesion. It was occupying the whole right hemithorax, but only involving the right lower lobe. Rest of the right lung was normal and expanded immediately after resection. As you see how it is like a cystic lesion, multiloculated, multiple, you can see them. So postoperatively, he did well, extubated after 48 hours, and then a CT, third post-op day, showed a complete resection. His ICD was removed after 9 days and discharged home. On the 10th post-op day, his histopathology came out on the 12th post-op day. So it did take some time. So according to our pathologist, they diagnosed this cyst as a pleuropulmonary blastoma. So we did not expect this diagnosis. And having that, we'll just discuss a bit of this. So pleuropulmonary blastoma is a distinctive rare primary neoplasm of the pleuropulmonary mesenchymal occurring in children. It is almost the only form of cancer that only originates in the lung of children, and it's usually intrapulmonary. It has the unusual biological features of arising in pre-existing lung cysts. So the historic view of it in 1945 was the first case that was described. 52, the term embryoma was used, 61, blastoma, and 88, pulmonary blastoma in adult, and pleuropulmonary blastoma in children. There were initially 3 types. The cystic, which is the type of our patient, then cystic and solid, and then they became 4. The 4th type was added by the registry in 2006. It was like a type 1R. It's a microarchitecture, and it regresses from the earlier type 1. These cysts are different from the CPAM that we suspected with this patient. There is a genetic predisposition, and the pleuropulmonary registry estimates that 40% of cases have a genetic basis. These are the genetic basis of neoplasia cancer family syndrome, with these in the list. And in 2009, the pleuropulmonary registry reported germline loss of function DICER1 mutation. We did actually find the same mutation in our patient. So it is very rare. 10 to 20 cases are reported in the United States. We reported 1 case in the Kingdom of Bahrain. They present from the newborn to 12 years, and according to the type. Type 1, the median is 9 months of presentation. Type 2 is 31 months, and type 3 is 42 months. So males and females are the same. 134 cases were studied in the registry to see what is the predominance, right, left, or bilateral, and right gave almost 50%. Symptoms and signs is mostly mild in type 1 and incidental, pneumonia in type 2 and 3. So because of rarity, nobody thinks of it when a child first has symptoms, and the diagnosis may not be made until a child fails to improve. So it's a spectrum, and it's a unique among pediatric cancers. Lung cysts
Sorry for the
precede-
interruption, Dr. Faiza.
Yes.
Can you please speed up the presentation? We have a discussion also after this. Thank you.
Okay.
Thank you.
So this is the spectrum, how a type 1 presents, and it may be type 2 with cystic and solid, and the solid is type 3. So it's totally different than the CPAM that we know. And there is a list of differential diagnosis. Surveillance is important, and it's mentioned to over 5 years, chest X-ray every 2 months, and CT every 6 months. Treatments is surgery followed by chemotherapy. In conclusion, pleuropulmonary blastoma is a rare disease but need to be considered in any child with a cyst in the lung, family history of childhood cancer, and the other list. These are the risk factors listed, and this is the address of the International Pulmonary Blastoma Registry. And thank you very much. This is our case that was published in Thoracic. Thank you very much for your time and for listening.
Thank you so much for the case presentation, Dr. Faiza. Now for the discussion part. So there are two different pathologies described in literature. There's a pulmonary blastoma and pleuropulmonary blastoma. Are they different or are they the same?
So I guess the question is to me.
Yes, sorry, sorry.
That's
Yeah,
okay.
all questions
So,
to the expert, please.
right.
Yes,
So, yes, pulmonary blastoma and pleuropulmonary blastoma are different pathologies. Pulmonary blastoma is seen more in the adults, while pleuropulmonary blastoma is seen more in children. A very basic pathological difference between the two is that in pulmonary blastoma, both the epithelial as well as the mesenchymal components are malignant. Whereas in a pleuropulmonary blastoma, what you usually see is that the epithelial component is formed of benign epithelial cells, whereas the mesenchymal component is the malignant counterpart.
So do they actually differ in the prognosis and treatment very much, sir?
Absolutely. So, in pleuropulmonary blastoma, Dr. Faiza has just highlighted that there are different types, right? So, based on those types, the treatment and the prognosis changes from type 1, which has a very, very good prognosis. And when you go to type 3 and type 4, the treatment again changes. You get neoadjuvant chemotherapy and RT that are added. Whereas a pulmonary blastoma, as I told you, it itself, both the parts are malignant. So it is definitely a very, very aggressive tumor.
So we are getting a lot of cases of congenital cystic diseases of lung, in which we explain them that it can be a potential risk factor for the development of pleuropulmonary blastoma in later stages of life, so that the parents get convinced about the early surgery. So what is your experience? Have you seen any such precursors of pleuropulmonary blastoma in your experience?
So I have only seen one case of pleuropulmonary blastoma till now. These are very, very rare cases, and almost all of them are reportable. So, definitely, as we know that these have DICER1 mutations, and when you see DICER mutations, they are multi-system involved, and you will see a lot of cystic lesions. You will have cystic hygromas, you will have nephromas, you will have thyroid, neoplasms, thyroid cysts. So these are all, when you see a spectrum of such illnesses, these all are a part where that you have to test at the genetic level, and these all have a potential to form into a much more sinister pathology. So these are cases wherein not just the index case, but you also need to see how the family is.
So DICER becomes then a mandatory test in this setting.
Absolutely, and especially when you are suspecting a syndromic infection in the family, you have to get a DICER done.
So apart from that, sir, any particular staging of the tumor that has been proposed yet?
So it has not really been, from a pathological perspective, the staging is not very clearly delineated. I think it's more in terms of radiology and, what I have discussed with my counterparts, I think as far as stage 1 and stage 1R go, the main radiological evaluation is of the chest as well as the abdomen. But as far as stage 3 and 4 go, you have to make sure that you see the brain and you also see the bones, because as you know, the DICER mutation will also show you many intracranial neoplasms as well. You can have penioblastomas, you can have all those things. So those are the kind of syndromic evaluation that you need to do.
So what our understanding of this disease is that the stage 1, the type 1, sorry, not the stage 1.
Yeah, stage is, I was telling you about stage.
Type 1 does not require
type 1 is a very, it's basically cystic, benign, epithelium is benign, and you have very few mesenchymal cells, which are the malignant cells. Type 2 is regressed, in which the mesenchymal cells are even lesser. Okay. Whereas in type 3, what happens is, you start getting more of the solid kind of a picture and nests formation in type 3. And type 4, you have an absolute sheet-like mesenchymal, high-grade sarcoma kind of a picture. So those are the types. They are not exactly the stages.
Yes, sir. The regressive form can be from the type 1 itself.
Yes,
the
yes.
Type 1, it can go into regression. Okay, sir. Next slide, please.
Before we move forward, I wanted to ask this same question to Dr. Hafeez also about the congenital cystic lesions of the lung. How many, sir, would have seen becoming malignant, sir? Dr. Hafeez?
I think this question is still debatable, whether the benign is the origin of the malignant, or are they just two different diseases? They look the same at some stage radiologically, but obviously there is some risk factor that points towards the diagnosis of malignancy more than benign pathology. One of it, obviously, the genetic part. If the patient has a dicer one, then this is likely to be a pleuropulmonary blastoma rather than a CPAM. And the symptomatology, among other things that will. The two things I wanted really to just first to congratulate Dr. Faiza for an excellent presentation and an excellent management of the patient. I would have not done anything differently. There is one pitfall that is repeated. I see it all the time in the management of pleuropulmonary blastoma, and I was actually almost hoping it's not during the presentation. It's not going to happen, which is like the insertion of the chest tube, but it does happen almost all the time in this kind of picture because it's so loose and so expansile and looks like as if it's causing a tension appearance, and so the knee-jerk reaction is to put a chest tube, and that's essentially obviously potentially hazardous. They can cause the tumor rupture and spillage and all that. But I saw the pictures from the surgery. It was wonderful how it was all resected intact. This is intact. It was perfect surgery. But yeah, this is something that if one sees a CT scan or a X-ray with an appearance of a cystic region, but not a clear cut pneumothorax, just to stop before doing the insertion of the chest tube. The other thing is what you've already all talked about is the screening, and we routinely screen for when we have a patient with dicer for all the other malignancies that can come with it. For in the abdomen, looking for the cystic nephroma or a Wilms tumor, or looking for the Sartori leading cell tumor in the ovary, or in the thyroid, as you all mentioned, the follicular thyroid cancer can be also associated with that, and etc. So they go through the whole screening workup. Thank you.
Dr. Sandeep, I would like to ask you one question. How many mutations, I mean, if you have this case, do you plan to do a mutation, or you just give treatment if you have this situation?
So we have just treated one patient of pleuropulmonary blastoma so far, and we were lucky to get him registered in the PPB, and they did the dicer mutation for us by hotspot, and we could do the germline mutation also. In ideal situation, in this patient, germline mutation should also be tested. But yes, I would like to do the dicer mutation at least for every patient with pleuropulmonary blastoma.
So was it negative or positive for your patient?
Was positive. It was positive.
Okay, okay.
And one thing more I would like to mention, that not only at the time of diagnosis we have to image brain, but even during the treatment and after completion of treatment, the patient may have recurrence of disease in the brain. So serial monitoring of the MRI brain is essential, because if we pick it up early, there's very good chance that we can still salvage the child.
Can I have the next slide, please?
Yes, Saurav, I think I've shifted the slide. Can you see?
No, ma'am, I cannot see. Yes, ma'am, now it has been changed.
Shall I take this?
Yes, sir. So regarding the chemotherapy regimen, sir, what we have learned that the type 1 does not have a very clear-cut guidelines of giving a adjuvant chemotherapy, while the rest type 2 and type 3 are.
Yes. So definitely in type 1, the role of chemotherapy is debatable. However, still many of the investigators give 6 cycles of vincristine and actinomycin in this patient. And this is basically because vincristine and actinomycin are associated with very few acute and late side effects. And there is some perception that this may prevent progression to type 2 or type 3, and sometimes decreases the chance of recurrence also. But I agree there is not very robust data to support this. However, in type 2 and type 3, chemotherapy is mandatory if we want to have a reasonable chance of cure. Now, depending upon the extent of resection that has been done upfront, or it is unresectable at the time of diagnosis, choice of chemotherapy can be modified a little bit. Active agent include ifosfamide, vincristine, and actinomycin, and addition of doxorubicin helps, especially in patient with R1 resection and in patient where the initial disease is unresectable, to a total cycle of 9 cycles of chemotherapy. So
Weekly. Is it a weekly regimen?
no, it's a 3 weekly chemo.
3 weekly.
3 weekly chemo. Yes.
So one of the articles on literature mentioned intracavitary chemotherapy is something like that.
So intracavitary chemotherapy has been tested more in adults, especially intraperitoneal and intrapleural. There is very less evidence and very less experience about use of intracavitary chemotherapy in children. There are only 2 case reports which have been published and which have salvaged these children with relapsed disease successfully. However, I would say that it is not standard of care for children, and I don't think there is too much literature about it.
And so what is the role of PET-CT and bone scan in the preoperative workup of pleuropulmonary blastoma?
So upfront, definitely every child with pleuropulmonary blastoma requires CT brain, MRI brain, and bone scan. PET scan is debatable because many a times, even during the treatment, they may have small focus of disease in the brain that may evolve during over a period of time. And in that case, MRI brain, I would be more comfortable doing a MRI brain because it can pick up low volume of disease in the brain compared to PET scan. And again, for local extent of disease, a CT chest, contrast enhanced CT chest will be better compared to PET scan. So role of PET scan is slightly, I would say, not very standardized in this case.
Okay, sir. Thank you, sir. Can I have the next slide, please? To Dr. Hafeez, sir, so how does the resection differ from that of the congenital cystic disease of the lung?
Yeah, it's obviously that the pathology is completely different. So resection is not always indicated for benign disease of the lung. Obviously, that's also debatable, but a lot of people would only resect symptomatic benign cystic lesions, while obviously pleuropulmonary blastoma has to be resected. And not only that, the approach for resection will dictate complete resection with negative margin when we're dealing with malignancy, specifically speaking about pleuropulmonary blastoma, while that is not necessary in case of benign congenital cyst. Although we do approach benign congenital cyst with care, just in case if it is a misdiagnosis of a pleuropulmonary blastoma. And so always the goal is to achieve complete resection, but obviously with more attention to margin and tumor spillage in terms of pleuropulmonary blastoma. The resection should be done and conducted in a way to prevent rupturing a cyst, spilling the tumor, or cutting across the margin of the tumor. And obviously, it takes also the same step of looking at the locoregional spread of the tumor, whether it's invading anything, was there is any visible enlarged lymph nodes, but obviously it's just like part and parcel of it. You have to assess and deal with how it look regionally.
So is there any margin defined that this millimeter should be taken as a negative margin in the resection?
I think the number is arbitrary. It's more from a pathologist standpoint to ascertain that the specimen include all tumor and a bit of normal tissue to basically be able to say you have an R0 resection. But that's pretty much it. But normally we have a leeway. We have, like, it's obviously we're dealing with most of the time one lobe of the lung or part of lobe of the lung, and essentially we always are able to leave a good margin of normal lung parenchyma.
Is there any lymph node sampling to go with it? Any mediastinal lymph node that should be picked up?
I think that's only would be for gross visible disease as part of the locoregional assessment, but not as a routine lymph node sampling that happens with other tumors in other part part of the body, or adult experience in a lung tumor. So it's only if there is something that it
So
looked pathological.
would you go for a lymph node that has been reported on CT, preoperative CT?
Yeah, I mean, if regionally there is something enlarged and look pathological, of course, that is a justified resection of the node.
So then how should we follow up these patients after the resection, after we are done with the chemotherapy? How should we follow up these patients?
Yeah, I think the protocol that was showed early on by Dr. Haider is a good protocol, a combination of more frequent X-ray and a little bit a further interval with CT scan. Well, is a very reasonable and good way of following them up. But obviously, it's important to do a good genetic analysis, and based on that, then design extra tests that are required, as has been discussed previously, in all these anatomical site where we know dicer family of tumor do occur, including the brain, the thyroid, the abdomen, the ovary, and the kidney.
And what is the minimum follow-up period, sir? Like, is it for 1 year or 2 years that we should be doing these investigations?
The rule of thumb for all cancer, the follow-up is at least 5 years, but for pleuropulmonary blastoma can expand beyond that.
Okay, sir. Thank you so much, sir. Can I have the next slide, please? So what would be the role of a radiotherapy in has sir joined already, sir? Sidharth, sir? I cannot see him. Is Dr. Sidharth sir already joined? Has he? No.
So I'm not able to see him. You can take the questions which are in the chat box if they're not taken yet.
Okay.
But I don't think that there is a defined role for radiation therapy for PPB.
In recurrence, sir, some of the literature reports that in recurrence, in severe cases in which the chemo has been also exhausted. So
Yes.
in those cases, after there is residual, after the resection and chemotherapy, radiotherapy can be given a trial.
Yes, absolutely.
We don't have any new questions, ma'am. We have covered most of them.
Okay, so I'll stop my slides from sharing and Dr. Sidharth will start.
Okay.
Good evening. I am just sharing my slides. And are the slides visible?
Yes, they are.
Yeah, Dr. Ravali, if you are there, can you unmute and start presenting the case of rhabdoid tumor, please?
Yes, I'm there, sir.
Yes, please proceed. I'll move the slides for you.
Good evening, everyone. My name is Ravali. I'm a first-year FNB fellow at St. John's Medical College. I would just like to thank everyone on the panel for letting me present today. So the child that we're going to talk about today, she presented to us. She was 6 months old, female child, first born out of non-consanguineous marriage. During a well baby visit at another center, they had incidentally picked up an abdominal mass. And on examination, which was done outside, it was about 4 into 4 centimeters, which was firm, palpable mass in the right flank, and rest of the examination was normal. So on subsequent imaging, it was suggestive of a well-encapsulated mass, which was arising from the lower pole of the right kidney without inferior vena cava involvement, which is seen in the image that is there. Next slide. So, in view of the age of the baby being less than 7 months, he subsequently underwent upfront right radical nephrourectomy as per the SIOP RTSG umbrella protocol 2016. And as documented by the operating surgeon, because there was a doubt of intraoperative tumor rupture, it was upstaged to stage 3. And on further histopathological examination of the tumor, it was noted to be a infiltrating neoplasm in the renal parenchyma with neoplastic cells with frequent mitotic figures which were noted. There was also renal sinus involvement and vessels which were noted. And another important point was that the neoplastic cells showed loss of expression of INI1. So that was our diagnostic feature. So coming to further evaluation, the site of the tumor was the right kidney. Germline mutations for SMARCB1 and SMARCA4 were negative, but the tumor biopsy testing was positive for the SMARCB1 mutation. On metastatic workup, your PET-CT as well as MRI brain were normal, and a diagnosis of malignant rhabdoid tumor of the right kidney with involvement of renal sinus and renal sinus vessels was made. So the infant was started on chemotherapy as per the URAB protocol, and she's continued to be on chemotherapy as of now. So I just want to give a brief introduction to rhabdoid tumors. So they are basically a rare and aggressive childhood cancer. They can arise in the CNS, soft tissues as the kidney. It's quite rare, so only about 2% of the childhood renal tumors, and they're usually diagnosed within the first year of life with the mean age being around 10 to 18 months. There's no racial predilection, but slightly more common in males, and 22 to 38% of the rhabdoid tumors of the kidney often have metastasis at diagnosis, so it's very important to screen for metastasis. So what causes these rhabdoid tumors is basically there's a deletion at the chromosome 22q11 involving the gene SMARCB1, also known as INI1, and there'll be a INI loss in the histopathology of the tumor, and a small population of patients may also have a germline or somatic mutation in the SMARCA4. So coming to the evaluation, the infant can usually present with any symptom related to intrarenal mass like abdominal distension, pain, fussiness, or fever, and sometimes hematuria. There can be associated synchronous or metachronous CNS lesions at the time of presentation, about 10 to 15% of children. And there also may be some soft tissue rhabdoid tumors like on the neck or back arising from the skin. So diagnosis usually is they present with a mass per abdomen, it's usually a USG or an MRI. If baby is less than 7 months, usually an upfront surgery will be done, like what is done with our child. And you have to look at the histology of the tumor as well as test for mutations. And it's usually defined by large cells of unknown origin that usually resemble benign or malignant skeletal muscle cells. And it's very important to also look for rhabdoid tumors arising from other sites like MRI brain, and to look for site of metastasis like by doing an FDG PET-CT scan. So treatment is multimodal, as we described. It usually involves surgery, chemotherapy, and radiotherapy if the child is diagnosed after 6 months of age. So just a little bit information about the rhabdoid tumor arising from the CNS, also known as atypical teratoid or rhabdoid tumor. Again, it's a rare, clinically aggressive tumor, usually diagnosed in children less than 3 years of age. It can be found most commonly in the posterior fossa and also linked to somatic mutations of SMARCB1 and less often SMARCA4. Presentation depends on the location of the tumor. So they can present with early morning headaches, vomiting, lethargy, ataxia, etc. So diagnosis usually by MRI brain and CSF analysis if there's no other clinical contraindication. Renal ultrasound to look for rhabdoid tumor in the kidneys, germline testing, and finally treatment is multimodal, which is surgery, chemotherapy, and radiotherapy. Prognosis is quite poor. So just I also wanted to talk about the rhabdoid tumor predisposition syndrome, which is something you might have to screen for in these children. So this rhabdoid tumor predisposition syndrome due to SMARCB1 mutations, it's also called as RTPS type 1. And if it involves a SMARCA4 germline variant, then it's called RTPS type 2. So it is suspected usually when a child presents with both ATRT of the CNS rhabdoid as well as a rhabdoid tumor of the kidney or soft tissue, or if there is history of rhabdoid tumors in siblings. So germline testing is usually recommended for children when they come with rhabdoid tumors less than 2 years of age, or you have multicentric tumors. And if a child is more than 2 years of age and there's non-multicentric tumors, but there's a positive family history, then we consider germline testing. Thank you.
Thank you, Ravali. We now move to the questions to the experts. So the first question is to the pediatric surgeon, Dr. Abdelhafeez. If you could tell us about when are the situations when you have a renal tumor, you will consider upfront nephrectomy. And in this, like in this index case, how can we avoid tumor spillage or rupture happening during the surgery?
I think Dr. Hafeez has left. He was on OT. So we have Dr. Shalini Mishra and Dr. Karim sir is also here. If they can take surgical questions.
Yes, sure, Monica. So the first
Thank you, ma'am.
question is, am I audible? Because I'm
Yes,
still
Yes, ma'am, you are audible.
traveling, so there may be some disturbance. Okay. So usually upfront nephrectomy in children. So it depends on whether we are following the PSYOP philosophy or the PSYOP protocol, or we are following the COG, which was earlier known as NWTS. So in COG, they would like to do upfront nephrectomy for most of the patients, whereas in PSYOP, we prefer to give preoperative neoadjuvant chemotherapy for 4 to 6 weeks, depending on whether it's metastatic or not. But even in the PSYOP protocol, there are indications where we do upfront nephrectomy, and one of them, most important, is that the age of the child is less than 6 months. And the reason being that most of the times it is more likely to be congenital mesoblasthic nephroma. Although in my experience, whatever the small number of cases I have seen infants or less than 6 months, they've all turned out to be Wilms tumor.
So I want to kind of reiterate whatever Shalini has said, that although we say CMN is very important in the actually first 3 months, not 6 months, Wilms tumor would still be the commonest tumor in the first 6 months. So that's something that need to be kept in mind. And I would suggest upfront nephrectomy in all suspected rhabdoid tumors, unless it's unresectable and you probably think that you will do the spillage. So tumor spillage in any renal tumor is one of the worst things for the baby. It will upstage the disease, it will be more common, second line chemotherapy will be more toxic. So we need to kind of, if you think you can't operate and remove the whole thing, then you might as well give chemotherapy and then wait and then go in.
Thank you, sir.
So, but we don't know most of the times unless we do a biopsy that it's a rhabdoid tumor or a Wilms, because radiologically it's very difficult. The other reason I feel why less than 6 months it is advocated to do surgery is because giving chemotherapy to a child less than 6 months may be definitely more challenging than a little older child.
So just a word there. I mean, one is that if it turns out to Wilms or something, you will have to anyway, adjuvant chemotherapy has to be given. You can't afford not to give adjuvant chemotherapy even if the child is less than 6 months. Secondly, unlike many, I would do True-cut biopsy for every renal tumor that comes to me. So if the True-cut biopsy picks up a definite tumor, then I'll operate accordingly. But if suppose it's Wilms tumor, or if it is the biopsy is inconclusive, then I'd rather give benefit of doubt of it being Wilms tumor and treat it accordingly. So less than 6 months anyway, go in and remove the tumor. But if it's more than 6 months, I would give chemotherapy and go ahead with it.
Thank you, sir. We'll move to the next question. So this is addressed to Dr. Sandeep. So can you tell us what are the clinical scenarios where we will suspect non-Wilms tumor from the history and maybe radiology also? And how does one approach staging in such cases of non-Wilms renal tumors like rhabdoid? And Sir Yogesh just mentioned, what is your comment about doing biopsy before starting chemotherapy when you're using the PSYOP protocol? Dr. Sandeep? Hello, Dr. Sandeep, are you there? Am I audible?
Yes, you are. You are audible, but I think we are not able to see Sandeep sir right now.
Yeah, Dr. Sandeep is not seen, so we can move to the next question. I'll just call him up.
Sure.
So we all know that if there is hypercalcemia and also concurrent tumors in the brain and all that, you should definitely suspect that to be rhabdoid. I mean, if you're just talking about the rhabdoid. But unlike many, I do Tukat biopsies for every patient. So it's not recommended. Now, SIOP has come out with the indications of doing Tukat biopsy in patients which are more biochemical, and that it's very well kind of written down in SIOP umbrella protocol. But I for one feel that the incidence of non-WHIMS renal tumors in the Southeast Asia, including India, is higher than what they see in the Western world. So probably it's not a bad idea to do a two-cut biopsy, because if you would give chemotherapy, which is for the WHIMS, may not work in others. So if you think the patient has got a unresectable tumor and you have to give chemotherapy before, then we probably would modify the chemotherapy and give something a little more toxic or than the ordinary WHIMS2 drug or whatnot.
Can the radiologist tell us about if there's any features on imaging that could help us to suspect a non-Wilms renal tumor?
We don't have any radiologist in this panel.
Right, no issues. I think that it's more aggressive tumor. I think there are few points, but I fail to remember. And usually, it's very difficult to understand unless you're doing a biopsy. Which the question said, is it mandatory? It's not mandatory by PSYOP unless there are some. The age is more than 7 years, or there are some atypical features on the radio imaging, which you're not clear whether it's Wilms or neuroblastoma, it's a suprarenal mass or a renal mass or whatever.
I'll move to the question for the pathologist, Dr. Kunal. Can you tell us about how we suspect rhabdoid histopathologically, and whether there is a role of compulsory genetic mutation testing in the tumor biopsy and in the blood for germline mutation status? I'll show your slides also.
Sure. So, rhabdoid histology is very peculiar. These are usually cells with, moderate amount of cytoplasm, and the nuclei are pushed eccentrically. And what you also see very commonly are intracytoplasmic hyaline globules. And these are, usually discohesive cells, but they still occur in clusters. So this kind of a morphology, when you see, you can, that rhabdoid tumor is something that you could suspect. We know that rhabdoid tumor could be a renal rhabdoid tumor. It could be an extrarenal rhabdoid tumor, or it could be even rhabdoid tumors, as has already been mentioned in the CNS, the atypical teratoid rhabdoid tumors. So that goes about the histological aspects. As far as mutation is concerned, we know that when we talk in particular, especially about a renal rhabdoid tumor, we know that, even in pathological diagnosis, loss of INI1 is considered to be pathognomic. And these are usually tumors which are associated with, SMARC B1 and SMARC A4 mutations. Most of these about 33% of renal rhabdoid tumors show these mutations in a germline approach, whereas there are few which also show mutations in somatic. What we don't usually see are missense mutations and splice mutations, but we also see, frame shift mutations are seen, nonsense mutations are seen, whole exome mutations are seen. So those are the kind of mutations that we see. So about 33% of renal rhabdoid tumors show SMARC B1 germline mutations, and those that show wild type for SMARC B1, we know that about 5% of those are associated with SMARC A4.
These are the slides that you had shared, the pictures of the biopsy that you have shared for a rhabdoid tumor child.
Yeah, this was actually a case I had diagnosed for in a liver biopsy, and we saw that SAL4 was positive. So there is a slight difference when we talk about extrarenal and renal rhabdoid tumors. So renal rhabdoid tumors will show INI1 loss is pathognomic in both, but renal rhabdoid tumors can also show you focal positivity for PAX8, focal positivity for WT1. And in that WT1 focal positivity, sometimes people, confuse them with Wilms tumor also. But as soon as you see an INI1 loss on IHC, you know that this is a rhabdoid tumor and you're not dealing with a Wilms tumor. As far as the the extrarenal rhabdoid tumors go, many of them can show you positivity for germ cell markers like SAL4 and Glypican-3 also. So there you have to be a little careful and make sure that if you are getting germ cell marker positivity, people should not jump the gun and call it a germ cell tumor. They should definitely put in an INI1 to see whether that is retained or is it lost. So as in this case, you can see that the tumor cells had expressed pan-CK, SAL4, Vimentin, and focally Glypican-3. Now, SAL4 and Glypican-3 are germ cell markers, but they are also expressed in rhabdoid tumors. And of course, in the next page, if you go, you'll see that there was characteristic loss of INI1. And on IHC, SMARC B1 is determined by INI1 loss, and SMARC A4 is determined by BRIG1 loss, BRG1 loss.
Thank you. Since the radiotherapy expert is not available, I'll just move to the, is Dr. Sandeep back to answer the questions on chemotherapy in rhabdoid tumor?
I can see him. I think he's joined.
Yeah. Dr. Sandeep, would you like to take these questions of how we approach chemotherapy in patients with rhabdoid tumor, and is there a role of doing autologous transplant in these patients? Dr. Sandeep?
I can see we muted.
Can you hear me now?
Yes, yes,
Sidharth?
we can hear you. Yes.
Okay, whenever we have a patient with rhabdoid tumor, the first thing we see is the surgical resectability of the tumor. If a patient can not undergo surgical resection, arterial resection is not possible. In that case, neoadjuvant chemotherapy has to be given, and in other cases, chemo has to be given after the surgery. Because it's a rare tumor and there is no standard regime for rhabdoid tumor, and the chemotherapy strategy is same whether it's a renal tumor or a extra-renal tumor. And the active agent in chemotherapy includes vincristine, actinomycin, and doxorubicin. And other agents which are used in the chemotherapy are ifosfamide, carboplatin, and etoposide. And as you have also shown in your case, the standard treatment that we are using now for rhabdoid tumor is European rhabdoid regimen, which includes doxorubicin high dose followed by ICE and VCA, and 2 blocks of these chemotherapy are given, and then patient is reassessed. And after that, depending upon the discretion of the treating physician, 3rd block of the same chemotherapy can be given, or patient can be taken for autologous bone marrow transplant. However, there is conflicting result about the role of autologous bone marrow transplant in this patient. It is purely, I would say, at the discretion of the treating physician, and overall results are same even if we continue chemo alone or we give autologous BMT for this patient. So this is, I think, the largest data that has been published for 100 patients with 70 extrarenal malignant rhabdoid tumor and 30 rhabdoid tumor of kidney by European group, and they have shown an event-free survival of 35% and overall survival of 45% with the same protocol. Next slide. And based on this, actually they have devised a risk stratification for rhabdoid tumor in patient where it is a non-metastatic disease and complete surgery has been done upfront and there is no germline mutation. These patients are classified as standard risk patient, and if any of the risk factor is present, it is high risk group, and the outcome in the standard risk patient is around 70% compared to just 30% in high risk group. So definitely, depending upon the risk group, one may try to see if autologous bone marrow transplant can help in high-risk patient, but right now there is no robust literature to support this.
Thank you so much, Andy. The next question is for this, any surgeon could address what is the approach to an extra-renal rhabdoid?
Dr. Sarin.
Yeah, I have very little experience with that, but yeah, brain is also. But we must know that if patient comes with a concurrent renal,
Lot of echo is there.
why is it echoing?
Yes, it is echoing. Shresi, can you help us? Shresi? Shresi, can you hear me? Has anyone logged in from double device? Hello? Shresi, can you hear me? Dr. Sidharth, will you say something?
Actually, I think it's echoing for everybody. Whoever speaks, it's echoing. From problem with the
Platform, I think.
Shresi? Shresi, can you help me, please?
I think she has lost connection, and maybe Dr. Shalini can take up this question if she's there.
I think the echo is gone. No?
But Shalini, we can hear you well if you
Yeah.
can take up this question.
Okay. So, extrarenal site, actually, it can be anywhere. It could be liver, lung, pelvis, extremities, brain, of course, is there. We have seen head and neck also. So, most often it's a very aggressive tumor, and then when we do a biopsy, we get this diagnosis.
Right. I think the main thing is we have to see whether it's a unifocal disease or a multifocal disease. So we need to do a proper staging, and in case we can go for the R0 resection and can remove in entirety, then we should go for surgery.
Most of the available. Sorry, it's echoing. Most of the patients who present with concomitant radial tumors and tumors, the really metastasis. They are two different tumors. So we need to kind of have germline studies done for the tumor separately.
I'll stop sharing and hand over to Dr. Saurav for the next case of pancreatoplasty.
Thank you, Dr. Sidharth. I'll be taking the next case of pancreatoplasty to be presented by Dr. Soumya.
But you need to resolve quickly.
Dr. Soumya, have you joined?
I have joined, sir.
But the echo problem is persisting right now.
Anyone
Internet team, can you help us?
Dr. Sandeep, can you talk when you are talking? There's no echo.
Even your voice is very clear. I can hear you very well. There is no echo in your voice also.
What about other people's voice?
I'm not sure whether it is with the.
Can you
only when
leave
Dr.
and
Sandeep
rejoin?
is speaking, there is no echo.
Dr. Sandeep, can you leave and rejoin?
How that will help? Sorry.
I don't know. Only your voice is clear. Everybody else's is echoing.
Okay. Let me try.
Let's try that.
Dr. Soumya?
Yes, sir. I'm heard.
Still echoing.
Monica, you have to take it.
Sir, I'm trying to reach my team, but they are still not replying.
Because
I mean,
it's
they're
very
trying to
difficult.
yeah. Shreyasi, are you there?
Yes, ma'am.
What is happening? Can you please help?
It seems like two devices are on, ma'am. So you have to off one device or remove.
It just got sorted out.
Yeah.
Were these two devices from your end, Shreyasi?
No, it's not, ma'am. Our end, ma'am.
Okay, it looks fine now. Please, I think let's go ahead.
Dr. Soumya, are you there?
Yes, sir, I'm here, sir.
Okay, please start the presentation.
Sir, can my slides be shared? It is appearing very small font.
I have gone full screen. Can you
Yes,
see
okay,
now?
okay. Yes, I'm able to see, sir.
Okay, please proceed.
Good evening. I'm Dr. Soumya, pediatric oncologist at Bharat Hospital and Institute of Oncology, Mysore. I'll be presenting a case of a 6-year-old female child who presented to us with complaints of pain abdomen on and off since past 1 month. Apart from that, the child was well. There was no complaints of fever, weight loss, vomiting, altered bowel habits, no complaints of mass palpable per abdomen. Next slide. On examination, she was well child, afebrile, no pallid icterus lymphadenopathy. There was a huge mass around 15 into 12 centimeters palpable per abdomen, occupying umbilical hypogastric left lumbar and left iliac region, firm in consistency, non-tendered, smooth surface, non-billetable, and we could get below the swelling. There was a reducible umbilical hernia also present. No signs of precocious puberty. So with this clinical presentation, we had kept the following differential diagnosis. Rhabdomyosarcoma, extragonadal germ cell tumor, neuroblastoma, adrenocortical carcinoma, and non-Hodgkin lymphoma. Next slide, please. So this child had done an ultrasound abdomen, but she had lost that report. She had also done a CT abdomen outside, and she presented us with CT report. It was a very large solid cystic lesion of around 11 into 16 centimeters into 8.5 centimeters, a retroperitoneal lesion with heterogeneous enhancement. And this mass was supplied by the branches of splenic artery. Posterior-medially, this was abutting body and tail of the pancreas with focal loss of fat planes. Apart from that, as per the report, there was no loss of fat planes with any other structures. Splenic vein was coursing through the lesion and causing the mass effect on, and this lesion was causing mass effect on large and small bowel loops abutting the IMA, common iliac artery, and left lateral margin of the urinary bladder with maintained fat planes. So their impression was a large, well-defined abdominopelvic solid cystic lesion, query accessory spleen to rule out neoplastic etiology. FNAC was attempted. This is the images of the CT scan done outside a very large solid cystic lesion with some areas of necrosis, and splenic artery was supplying this lesion, was coursing through the lesion. FNAC was done outside, which was showing cellular and small monomorphic round cells arranged in pseudorosettes, sheets, and singles, an isonucleosis and hyperchromatic nucleus, granular chromatin, inconspicuous nucleoli with moderate amount of amphiphilic cytoplasm with background fibrillary tangles. So they were of the impression that it could be neuroblastoma. So when the child came to us, we got a whole body PET CT done. There was no evidence of metabolically active lesions anywhere else except for this lesion. But however, our radiologist reported it to be an intra-abdominal mass lesions. They were not ready to commit to the lesion being arising from the retroperitoneum, nor they were able to tell us where the lesion was arising from. However, there was abutting of the body and tail of the pancreas, and the lesion measured around 12.9 into 8 into 16 centimeters. So up till now, through the imaging, we were not able to tell where the lesion was arising from, and it was a non-metastatic intra-abdominal bar retroperitoneal lesion, and outside FNAC was suggestive of query neuroblastoma. We got all the relevant investigations done, and on tumor markers, serum AFP was elevated, beta HCG and LDH was normal. We were of the suspicion it could be a germ cell tumor, bar pancreatoblastoma, because pancreatoblastoma is known to have elevated AFP, but though imaging wise, we were not able to tell where the lesion was arising from. So we went ahead with true cut biopsy, and it was suggestive of malignant small round cell tumor. Next slide, please. Monomorphic round or cuboidal cells with hyperchromatic regular nucleus, and they were arranged in nests, microacini and cribriform patterns, but mitotic activity was very scarce, and there they clearly mentioned there was no evidence of necrosis or squamous metaplasia. So they requested IHC markers to be run, and on that cytokeratin, chromogranin A, CD10, E-cadherin, beta-catenin were positive, and negative for synaptophysin, WT1, CD57, PAX8, and SOX11. So they gave the impression that it is most consistent with pancreatoblastoma. The Ki67 was just 2%. So this was a locally advanced upfront unresectable pancreatoblastoma. So we plan to give 3 cycles of neoadjuvant chemotherapy with the Plado regimen. And after 3 cycles on reassessment CT scan, we could clearly see that there was definitely more necrosis compared to the upfront scan. However, the size of the lesion was almost similar to the upfront scan, just with around 1 centimeter decrease in the size. So this case was discussed in the multidisciplinary tumor board meeting, and the surgeons were of the opinion that R0 resection in this case might be difficult. So they suggested us to consider more chemotherapy. The question of whether to continue with the same chemotherapy cycles what we used versus considering the second line chemotherapy was put forward. In multidisciplinary tumor board, we felt that since there was some response to the Plado regimen and there was more necrosis compared to the earlier scan, we thought of giving 2 more cycles of Plado and then again reassessing. So the questions to the tumor board would be, the questions to the webinar people today would be, what are the chemotherapy options that we can consider upfront? And what are the first line and second line chemotherapy options? Is pancreatoblastoma chemosensitive, really chemosensitive, like it is described in the literature? And for those pancreatoblastoma which are upfront resectable, is there role of any adjuvant chemotherapy? What is the role of radiotherapy? What is the overall prognosis in these cases of pancreatoblastomas? And what are the treatment options for relapsed pancreatoblastomas? So very small gist of the summary or takeaway points would be pancreatoblastoma are very rare tumors arising from epithelial exocrine cells of pancreas. Most common in children less than 10 years of age with mean age of diagnosis around 5 years. It is the most common pancreatic tumor in children. The etiology is unknown, but it is more commonly associated with the syndromes like Beckwith-Widman syndrome and familial adenomatous polyposis. It is likely to arise from head or the tail of the pancreas. The children present with the usually asymptomatic mass or very vague symptoms like upper pain, abdomen, vomiting, feeding difficulties. Jaundice is very rare in these cases. Because of the rarity of these tumors, the early diagnosis of these tumors are difficult, is challenging. So most of the times they can even present with the metastasis. Metastasis is common to lung and liver and lymph nodes. So on histopathological, these present as small round cell tumors with multiple line of differentiation into acinar, ductal, mesenchymal, and neuroendocrine. Squamoid nests presence is very specific and it indicates the growth pattern. So the chemotherapy options considered are like how we treat hepatoblastomas, that is Plado regimen, cisplatin and doxorubicin. IS is one more chemotherapy options, and vincristine, actinomycin, and cyclophosphamide are the chemotherapy options. For those which can be resected upfront, surgical resection remains the mainstay of treatment.
Thank you, Dr. Soumya. Now we will have the discussion part. Is Sandeep sir here? Sandeep sir?
Yes, I'm here. Yes.
Sir, how to evaluate this upper abdominal mass arising from pancreas and blood test in the imaging study to guide? Which imaging study will you prefer to have a diagnosis?
So if we have a child with some abdominal mass, the first investigation is always ultrasound abdomen. And definitely it will give us some idea about the location of the tumor, from where it is arising, whether it is a solid or a cystic lesion. Then next investigation is triple phase CT abdomen for this patient. Now, because we know that this is a mass which is arising from the pancreas, so the CT will give us some idea about the extent of disease, relation to the adjoining structures, and also relation to vessels which are nearby. So blood investigation wise, I think AFP is the most important thing that we should do, because we know that almost most of the patients with pancreatoblastoma have increased AFP. Then if we have a suspicion of pancreatoblastoma, then we need to do staging workup. And staging workup, this tumor generally goes to intra-abdominal lymph node, lung, and liver. So CT abdomen will cover intra-abdominal lymph node and liver as well. And CT chest should also be done to look for metastasis.
So how is the incidence of metastasis to the lungs? For liver, we know that it metastasizes to liver, but how is the
it's
lung?
just 1 to 2% only. So it's very rare, but to be very honest, I have never treated a patient of pancreatoblastoma. This is just what is mentioned in the literature, that CT chest should also be done as a part of staging workup.
So any role of PET-CT in the preoperative workup?
So like because the most of the time the disease is just confined to abdomen, and even metastatic spread to the liver, lung is also very uncommon. In that way, PET-CT is unlikely to give any other information. So generally, it is not recommended.
Sareen sir, are you there? Hello, Sareen sir?
I have no experience. I have nothing to really add. I mean, this is something which is really.
So another aspect is how to plan a biopsy in this case, because the case presented was they have taken a true cut biopsy. In some literature, it is mentioned that they have, during exploration, they have taken an open biopsy. In one of the articles, they have published a laparoscopic biopsy as well. So what should be the correct way of doing a biopsy in a pancreatoblastoma?
In a large tumor, like I'm speaking generally. I mean, I'm not talking about pancreatoblastoma. In a large lesion like that, ultrasound or CT guided true cut biopsy is as good. I mean, of course, we can do laparoscopic, but I think from all regimens, including COG and all that, the open biopsies are really gone. I mean, nobody does laparotomy and do the biopsies anymore.
It can be more of an accidental thing if we have opened for anything else.
I just wanted to add something, that this particular case, the tumor was encasing the splenic vein, and as it's mentioned, they did think about neuroblastoma as well. So we could do the urinary VMA, HVA as well in this case, because that's much more common than this rare pancreaticoblastoma. And also, I'm just thinking, of course, we need to see more images, whether it's possible to do surgery along with splenectomy. Because in pancreaticoblastoma, I think this good surgery with clear margins is the most important prognostic factor about the outcome. So suppose if it is arising from the head and head area of the pancreas, then we may just have to do Whipples, not just a resection of the tumor, we may have to do Whipples as well, even in a small child. Again, a few cases I've seen, but none of them we could manage with surgery. In fact, the patients just came, showed, and they lost to follow-up. They couldn't accept the risk of surgery and etc. etc.
Just Dr. Shalini, suppose we know that this tumor is arising from the pancreas. Would you like to do biopsy percutaneous or endoscopic biopsy is also an option in this patient?
For smaller tumors, I think endoscopic biopsy is an option. Sometimes if we have the suspicion of those pseudopapillary pancreatic neoplasm in older patients, we have done endoscopic biopsy. But for such a large tumor, I think it's not required. We can easily do ultrasound guided or CT guided Truecut biopsy.
So this is for Dr. Kunal, sir. How will we differentiate the different pancreatic tumors from pancreatoblastoma histologically?
So in histology, pancreatoblastoma, as has already been mentioned, it can show you a variety of morphologies. Most commonly, you see the acinar morphology, and those are the tumors that you need to differentiate from the acinar cell carcinoma. Then you can also see, ductal morphologies. You can see neuroendocrine morphology, in which you have to differentiate that from the neuroendocrine tumors. And basically, what helps you differentiate is the immunohistochemistry. In cases of neuroendocrine tumors, they show very diffuse synaptochromo CD56 positivity, whereas in case of pancreatoblastoma, you only see very focal synaptochromo positivities. Plus, based on the morphology, you will see beta catenin expression, because we know that pancreatoblastoma is associated with 11p loss and the beta catenin pathway. So that can help you differentiate. Then, these are usually tumors with very low Ki. I think one of the points that Dr. Shalini really brought up, especially in this case, you also always have to be very careful about a neuroblastoma. Sometimes you can have metastatic neuroblastomas very rarely, which can actually come in pancreas. So these are, few clinical scenarios where you have to take things with a pinch of salt. But then most other places, things are pretty much fine. And the association with Beckwith-Wiedemann syndrome has already been told. So,
any role of testing the tissue AFPs in these cases of pancreaticoblastoma?
Tissue AFP, especially when AFP serum AFP levels are high, in those cases you can have AFP positivity, but that will not give you much, because AFP positivity is seen in liver cancers, it is seen in germ cell tumors. So, it can be a corroborative finding in case your serum AFP levels are high.
That will make it stand out from neuroblastoma, won't it?
Yeah.
Okay. So how to go about it surgically? If Shalini ma'am or Sareen sir would take this question. So what would be the surgical procedure for
So
this
basically, it has to be a excision with negative margins and avoid spill, because as it's mentioned everywhere that surgical resection is the most important treatment here. They're not so chemoresponsive. So if necessary, we may have to do Whipples or splenectomy, whichever way, depending on the imaging. But in the couple of cases that I've seen, those patients, it was quite a difficult surgery, and the relatives did not accept the morbidity of undergoing Whipples and things like that, and they were just lost to follow.
The bottom line is that unlike neuroblastoma, you can't do piecemeal. You have to excise it, with negative margins possible, if you want to kind of give a good chance to the patient. That's it.
So the attempt
However
should be at
extensive it
R0
could be.
resection.
Yes, R0.
So ma'am, any criteria to determine preoperative operability of the tumor?
Like
That's
we have
very
also, we have something in adults like pancreatic tumor hai to itna encasement rahega, we will operate. So is there any criteria for pancreatic tumors also?
I'm not so much aware about this, but usually we would discuss it with the radiologist, and definitely a good CT under sedation with all the vessels visualized well would help us to resect, to decide
I
the
have personal
resection.
experience only one tumor in the head where I done Whipples, so where R0 section could be done. But the large tumor that you've shown is amazing, how to go about it really.
what will be the comment on the positive margin? And is there any role of radiation in this particular tumor? How much margin should we take for a negative margin to have, like in millimeters? Is that defined in the resection?
I wouldn't know. I wouldn't know. Sorry.
So Laskar sir is not there, and I think radiation is not applicable here. Only in cases where we cannot do anything, we look for radiation oncology to help us. This has been done when I was in Tata. We did it for liver tumors also, hepatoblastoma. So, and even GCTs we used radiation when we had no other choice and patients wanted treatment. So I had experience of 3 pancreatic tumors, but that was when I was in TMH. One was in tail that was sorted. We did frozen section for the margins. One was Whipple, but that was for SPEN, I think the histology. And other pancreatic patient tumor which we operated was with the GI team, and it was adult girl, so it was manageable. We took their help because those the canals are they're very small to suture, so that we took their help. So these are the 3 patients I have some experience, and probably 1 or 2 we just sent back because we couldn't do anything. So there's no margin limit, but negative margin and frozen section can guide us whether we need to repeat the margin or not. This
Yeah,
is
I
what
would agree
have.
with Monica. There is no definite role of radiation, but suppose a microscopic margin is positive, people have used in the literature, they do mention that radiation could be given, but the role is not very well defined.
Another scenario, we have that pancreatoblastoma with liver mets. If it does not subside or get treated with chemotherapy, what are the treatment options after that one?
So generally, first line of chemotherapy is Pledo, which includes cisplatin and doxorubicin. And if patient is not responding to it, the overall outcome remains very poor. But salvage option include ICE chemotherapy, which is ifosfamide, carboplatin, and etoposide. Some people have used gemcitabine 5-FU and 5-FU also, but as such, I don't have any experience of using these agents.
Is there a role of autologous stem cell rescue? Somewhere it's mentioned.
So autologous bone marrow transplant only help if it's a chemosensitive disease. If it is a chemo-resistant disease, autologous BMT doesn't help. You should have good amount of control with your conventional chemotherapy, then you can consolidate with autologous BMT. In a chemo-resistant patient, autologous BMT is not going to help. Like in neuroblastoma also, we do autologous only for patients who achieve remission, who have like good disease control. Then only autologous BMT helps.
Last question of the day, are there any palliative procedures if we are not able to operate the primary tumor? Shalini ma'am or Monica ma'am can take this question.
So I guess if there is a duct obstruction, we could either do some external drainage if that would be possible. I mean, in this kind of a patient where there's a huge tumor, you wouldn't want to go in and just do a drainage procedure, but that could also be a last resort, a jejunostomy, drainage or whatever. But we would, in the current era where the IR people are quite proficient, or we could even take help from our gastroenterologists to do a stenting in case there is a duct obstruction that is causing significant pain and symptoms. Anything else, Monica?
With all these, Ivan, I was about to ask whether there's any experience on endoscopic stenting. So with all this stenting, and if does chemotherapy has any problem when we give chemotherapy to these patients? Chances of pancreatitis or something, does it increase?
I guess there may be a little bit more higher chance of infection or stent infection or something. But we'll have to actually weigh all ends and see how much benefit we are actually going to give, especially if it's a palliative setting and we're not looking at the curative intent.
Yeah, but pancreatic duct stenting is difficult even in benign issues of pancreas, Even a simple chronic pancreatitis is not very easy to kind of go in and put a stent, really. So I don't know in this kind of scenario, as they have discussed, whether stent can be put.
Do we have any questions from the audience, or would anyone like to raise a comment or something?
Cannot see, ma'am, any new questions here in the chat box.
Are there any questions? Because I couldn't see any questions there. No, I don't think there are questions there.
Yes, ma'am.
Yeah. So I think we'll just wind up the session. Thank you, Dr. Sandeep, Dr. Sareen, Dr. Shalini, ma'am, to help us out and others to join. Thank you, Dr. Faiza and others who have joined. And thank you,
Thank you,
Dr.
Monica.
Siddharth and Dr. Saurav.
Thank you,
Yes,
Dr.
ma'am.
Monica, for coordinating.
I just wanted to say something. 3 cases was much better than 4 cases. We didn't go until 9 p.m. I think for the
Yeah,
future, just keep 3 cases. 3 cases is
I
fine. We had
told
a good
her that you will
discussion.
keep 2 cases and discuss 2 cases and no one this thing.
I got message in the morning 9 baje khatam hoga kitne baje khatam hoga, so I had a
हाँ,
target of
मैं
8.
सुबह इसको पूछने लग गया था कि आज 9 बजाओगी कि 8 बजाओगी, क्या करोगी? So I think 2 cases are good enough. I discuss 2 cases in more detail maybe, and then we always have time. The next time, no issues about taking them again. I mean, trust me, Monica, they are very, very educative sessions even for us. So keep doing it, but don't put so much on the plate that indigestion occurs, you know.
Okay, Dr. Faiza, you want to say something? Dr. Faiza is from Bahrain. She's joined us, and it was a nice.
I would like to thank you, Dr. Monica, for always get sending me the message. And this time it was a rare disease, so I really shared our case. So it was the first and maybe the last so far, inshallah. We don't have, this was the only pleuropulmonary blastoma that we had. And gladly it was a type 1. That is quite interesting from everybody. Thanks for sharing your experience. And thank you for having me. It was quite interesting. Thank you. Thank you.
Dr. Shalini ma'am and Dr. Sareen sir, I'll just ask one question because I have seen chest tubes in these cystic lesions. Then I think you were not there initially in the session. So when these cystic lesions in the lungs come, how do you decide whether it's the pleuropulmonary blastoma or a benign thing? Is there any radiological sign or is the clinical sign which you judge by?
You know, the type 1, it will be impossible to say. So just like any emphysema, lobar emphysema, people have been putting chest tubes, and I won't blame them really. But if you see a solid this thing, surely you should not put a chest tube.
This is something we often see, that the chest X-ray shows a kind of whiteout lung, and the first response of anybody if the child is in distress is to put a tube. And later on, we find that there's a solid mass inside or whatever. So I guess just an ultrasound or something of the chest would help. But in case of an emergency, child is in distress, somebody puts a chest tube. I mean, you can't help it. We see it very often. And as it is the case with pleuropulmonary blastoma, majority, I think almost more than 90-95% of the times, it is never diagnosed pre-surgically. It is always diagnosed later on.
And another thing I wanted to say was that pulmonary blastoma can also be seen in the childhood. It's not that they will be only in adult. I've seen it in a much younger child. So both tumors could be there. Yeah. Thank you so much. Thank you.
Thank you.
Nice. Next time, maybe only 2 cases, but have good discussions. And share recordings if possible, please. Tell this ClearNet people that they could share that will be a good kind of video library with us to kind of go back to and have a look.
So we have a YouTube channel which I will share with everyone. So we have all the previous recordings there. And
Great.
Thank you everyone for joining in.
Just
Dr.
let us
Sandeep,
know all that you've done till date in one email or on the WhatsApp. Thank you so much.
Sure. Thank you, sir. Thank you, everyone. Thank you.
Thank you.
Yeah, bye. Bye.
Thank you, ma'am. Thank you so much, everyone, for giving us the opportunity to host the session. We hope to have you again on our platform very soon. Thank you. Good night, everyone.
Thank you. Good night.